I wanted to thank Peter and the conference organizers for inviting me to be here today. It's always an honor and a privilege to be able to speak about such things to a compassionate audience. So I was asked to address the issue of research within the context of a Down syndrome clinic, and pretty much that's the model that we've employed for some 15 years since our Down syndrome clinic was established at Kennedy Krieger. So I'm going to tell you a little bit about that now this afternoon. Please notice I've added the apostrophe S to Down syndrome to honor people from the UK. Of course, in the States, we drop the apostrophe. Just call it Down syndrome. And here's some picture of some beautiful children from the States. And I thought I'd start off with this picture made available from Roger Reeves at Johns Hopkins, showing the third copy of chromosome 21. So let me give you just a little bit of history from my perspective on these Down syndrome clinics and how I think they came to be. Of course, in the early part of the century and up through around the 1950s, many individuals were cared for in large institutions. There may have been academic physicians affiliated with those institutions who had some interest in Down syndrome and provided us with many fine descriptions of not only the general condition, but what we now appreciate as a lot of the associated medical issues. By the 1950s and certainly the 60s, especially as individuals started to come out of institutions or not be put in institutions at all, their care was managed more by general practitioners and specialists referred to at the time as dysmorphologists. We now think of them as geneticists. And there were some clinics that were established early on in the 60s. In Iowa City by Dr. Zellweger, in Seattle by Dr. Smith, and in Boston, Dr. Clemens Benda was affiliated with the Ferdinand School in Waltham, Massachusetts. So these were some of the early pioneers who kind of predated the modern Down syndrome clinic movement, but who were able to make substantial contributions just because of their personal and academic interest in the condition. And, you know, there's a host of people who even preceded them who I've somewhat omitted, both from the UK and from the States. And in fact, it's probably a worthy history that should be delved into in a more formal way. By the 1970s, developmental pediatricians became more interested and started to establish clinics for children with Down syndrome, primarily because in response to what parents were telling them, that they wanted more than to just know the child had trisomy 21. They wanted some guidance around issues of development and education. And pediatricians seem to be a natural source of that information. Of course, by this time, the role of developmental therapists had been well recognized, and they were included in these early clinics, and of course, medical specialists. I probably underestimate the number of clinics here as 20 to 30, but it's been steadily growing, and now we heard from Romney that there may be as many as 50 to 60 clinics around the states. I think no two clinics are quite alike. Some of them are well known as specializing in Down syndrome and have a team that's really focused on that. In other situations, it may be a developmental pediatrics clinic that sees a variety of developmental disorders of which Down syndrome is a part. But you know, it doesn't mean that they don't have the expertise to do a very good job. I think in many cases they do. So what is the function of these clinics? Well, multiple. I think evaluation of children is clearly the primary role that most of these clinics play. In addition to providing education and guidance to parents and families, screening, doing preventive medical screening, and referring to specialists as needed, if needed. Consultation for some of the medical problems that have been defined or described. Sometimes parents want to come and just discuss whether the implications are any different because of the fact that their child has Down syndrome. You know, will they necessarily have any particular complications specific to the Down syndrome? And sometimes the clinics get involved more with aspects of treatment. And I think that in general, these specialty clinics, the way they're set up, is to supplement the role of what goes on in the community. As you heard this morning, the primary care physicians play the role of primary caretaker, and we have developmental services that are available in the community and in the schools. So they may come to our clinic just for a consultation primarily. The organization of these clinics involves both parent and professional collaboration, academic, physician, and hospital collaboration and partnership. And these are the two biggest kinds of collaboration that need to happen in order for these clinics to really be successful. Many of them are within departments or divisions of pediatrics. Like I say, some of them are run by developmentalists, some are run by geneticists, and more recently, some will be run by neurologists. The DSMIG, or the Down Syndrome Medical Interest Group, is an informal network of physicians and healthcare workers in the US, but also in the UK, and in fact, it's becoming more international in flavor. And I think that that's a positive step, to have a group of people who are consistently interested in learning more and raising the standard of care for people with Down syndrome. Now, over the years, the model of our clinic and the types of evaluations that we do has changed somewhat. I think when we first started, we primarily catered to preschool children and to young school-age children, elementary school years. And using a developmental approach, developmental model, those evaluations would consist of, in addition to a medical piece, usually a hearing test or screen, maybe a psychological or educational type of evaluation, consultation for motor therapies and speech therapies, perhaps a consultation for nutrition or feeding, those kinds of things. And that was sort of how many of these clinics started off. Like I say, they were run by pediatricians and catered to younger children. I think over the years, there has been some tendency for us to deviate from this model for a number of reasons. Number one, it became clear about 10 years ago at least that insurance companies were not going to pay for these rather extensive evaluations. You know, they would claim, well, these therapies are provided free in the community, and if the child's enrolled in public school, it's the public school's position to be evaluating the child and providing therapy. So if parents were going to have to pay out of pocket to have this large menu of evaluations, you could see that would be quite expensive and not very practical. So now parents kind of pick and choose, rather like ordering from a Chinese menu, of services or evaluations that they would like their children to have. So we can put together any kind of a combination of evaluations. But we don't do this on everybody the way we started out to do 15 years ago. I'd say more often we are seeing children who have complex neurodevelopmental manifestations or concerns, and behavioral and mental health issues. And this can involve school-age children and young adults. And for these types of evaluations, in addition to a medical component, they may be seen by a psychiatrist, they may be seen by a behavioral psychologist, and possibly others as well. And here, our focus tends to be more on behavior management, ensuring good functional communication skills, because communication is often an issue in these situations. And I'm involved in medication management and trying to come up with some measurements of outcome, because I think this is something that we really need. We also see adults and can see them typically under this kind of a model, but occasionally we'll see adults who are doing well, there's no mental health concerns, and the parents just want to come for a checkup to be sure that things are going well, and when I see them, we'll do some of the screening for thyroid and for some of the medical issues that maybe haven't been attended to for quite some time. So that's the current way in which we function. This is just a graph of the number of visits we've had since around 1991. You can see last year we had about 500 visits. And this is a clinic that operates 2 full days a week. Just to show you, this 500 probably represents about 325 to 350 individuals, but a number of them were seen more than once during that year. They would come back for follow-up. So 500 visits. So we've probably evaluated around 1,500 individuals with Down syndrome since 1991. Now, at Hopkins, there has been a tradition of research in Down syndrome well before I arrived on the scene. During the 80s and 90s, a geneticist there by the name of Stelios Antonarakis was interested in the origin of trisomy, and he was also interested in gene mapping, identifying the genes on 21. He's still involved in this. He now works in Switzerland. Genetic engineering of mouse models was pioneered to a very large degree by people at Hopkins. John Gearhart, Richard Reeves were very instrumental in those early efforts. And Joe Coyle, interested in studying the neurobiologic manifestations of trisomy in these mouse models. I had the opportunity to work in his laboratory for a couple of years before I started at Kennedy Krieger. There were people working in dementia, looking at essentially at people over the age of 40, 45, trying to develop screening methods for dementia, trying to define the psychological profile and the imaging profile. And we even had someone who was interested in sleep apnea. So there's been a history of work that's been done there. Sad to say that a lot of these people have moved along. In fact, except for Richard Reeves and John Gearhart, they've all moved on. And now we have a collaboration looking at the genetic basis of the AV canal defect in people with Down syndrome. And that's in conjunction with Roger Reeves and Stephanie Sherman at Emory University in Atlanta. So it's a multi-center study. And the basic question is why don't all children with trisomy develop AV canal defect? Why is it that some develop no structural cardiac disease whatsoever? So there may in fact be genetic modifiers on other chromosomes that are responsible for the expression of the genes that are on 21. So that's the hypothesis that we're pursuing in that study. Now, when I came to Kennedy Krieger, we were interested, or I was interested in doing more translational studies, the kinds of things that could be done with the clinic population at hand. I thought it was, actually we had gone through so much effort to establish the clinic that it seemed like with 10 or 20% more effort, we could possibly get a new kind of benefit from the clinic. And I think we've been pretty successful at that over the years. Some of our studies have had NIH funding or pharmaceutical industry funding. We did some studies in the mid-90s of brain structure of individuals, and this was funded by our Clinical Research Center at Hopkins, which receives funding from the National Institutes of Health. We've done a clinical trial of donepezil, which is one of the Alzheimer's medications that's reported to help with memory. We did this study with funding available from Pfizer. Paracetam study was done largely with private foundation funding. That was done in the late 90s. We spend a lot of energy and effort looking into this whole issue of behavioral and mental health issues. We have a particular interest in kids on the autistic spectrum, kids with disruptive behaviors, and young adults and adolescents with mood disorders. So we're interested in both characterizing the phenotype and being able to have some better descriptions and some numbers attached to those descriptions, as well as being able to measure the outcome after medication therapy. And we've also been involved in some biochemical type of studies. If I have time, I'll tell you about our study of mitochondrial function, looking at reactive oxygen, which we found to be increased in individuals with Down syndrome and may contribute to some of the aspects of precocious aging that we see. And we've also done studies of amyloid precursor protein, which is a protein that's coded on chromosome 21. It's present in a third copy, and we think it's a pretty major player in the development of Alzheimer's disease, though we don't quite understand exactly how it leads to Alzheimer's, or if it's certainly not the only factor, but it's an important factor. And we've looked at peptide processing in children. I mean, there's been a lot of work, or some work done in adults, elderly with Down syndrome, but very little known about what happens in children. So what you see, or what I've tried to show you, is that we have kind of a mixed portfolio of funding sources, both government, pharmaceutical, private foundation, and some of it just done on sweat equity. And we have both basic and clinical research collaborations. And I found this to be kind of a nice model, because in addition to the clinic helping us to come up with hypotheses and research questions, it aids both in the recruitment of subjects and just in getting these studies done in a timely fashion. But we also find that the fact that we're involved in research helps families who want to come for just a more traditional clinic evaluation, who feel somewhat reassured, that we know what we're talking about because we're involved in the research end of things. We have a flexible research infrastructure and personnel, which is kind of a kind way of saying we hire and fire people based on our funding situation. It's not quite as crude as that, but we basically have to be flexible. We don't have people that are paid for on staff to sit around and think up of research ideas. I wish we had that. I wish we had research fellows and faculty who were paid to do that, but that's just not the way it works. The funding has to come first, it seems, and then you can hire the people to do it. So it's one of these catch-22 situations. I think the importance of this kind of work is that parents desperately want and need this information that's specific to Down syndrome and not just a general account of children with mental retardation or intellectual disability. It needs to be specific to Down syndrome. And I think professionals need to know and have this same information as well. In addition, it may be helpful for people who don't have Down syndrome, but who have congenital heart disease, or people who don't have Down syndrome but have intellectual disability and mental health disorder. So it's likely that we're going to be able to find some important information or treatment that may apply to this population as well. The challenge is to keep pace with the rapid changes in medical science and medicine in general. I think Down syndrome clinics in the US do a pretty good job of meeting the needs of the younger child using this developmental model. But I find that the developmental model breaks down and loses its relevance when we get into children of an older age and certainly adults. We need to be drawing on different ways of thinking to help understand them and solve their problems. Obviously, aging, those with complex medical and behavioral needs need kind of a special approach. We've been slow to develop evidence-based practices. I mean, we know intrinsically the benefit of doing thyroid screening, or we know the benefit of doing vision and hearing screening, but no one's demonstrated the economic impact of doing that screening. I mean, there's a general consensus that it saves money in the long term and that it improves health in the long term, yet the data apparently is lacking, and I don't think we can operate that way for much longer. We've been slow to develop formal clinical and research protocols and to develop a database from which to operate, and I think we're at a point where we clearly need to do so. I think we're not doing a great job managing or screening for behavioral and psychiatric problems on a regular basis, or knowing whether the medications that are commonly used are beneficial, or if there's more or less of an incidence of side effects in people with Down syndrome. I'll go on. The genetics. We don't understand how having an extra copy of chromosome 21 leads to the phenotypic effects that we call Down syndrome. Why is it that 50% have structural heart disease and so many don't? Why is it that, 5 or 10% have structural GI defects and the rest don't? Or the same can be said for autism spectrum. So these are important questions that need to be addressed, and I think are beginning to be addressed through a genetic approach. The neurosciences is ripe for more research, both in terms of functional neuroimaging, which allows us to function the brain as it works and processes information, particularly in the areas of memory, cognition, and language. And last but not least, we need to be doing a better job training people to carry the ball into the future, both service providers and researchers. There's not a lot of people, it would appear, who want to specialize in this area. And so we need to find a way to improve that situation. So the next steps for what's being planned in the US at least is bringing together a diverse group of people who all have a stake in Down syndrome and trying to create a broadly defined research coalition. These are people from the national organizations, people from parent groups, academic researchers, people from government research and disability agencies. And there are some goals that have been put forth. This research coalition has actually met 2 or 3 times, and there are some subcommittees that are at work behind the scenes trying to develop and define short and long-term research goals with the specific purpose of being able to increase government and private support for research, formalize clinical research networks and databasing efforts, and to possibly even develop centers of excellence that could serve as a model for other clinics, and to provide necessary training for service provision and for research. So that's kind of an ambitious new goal that's being discussed at the moment. Now that was the general commentary on Down syndrome clinics. And I'm going to now talk a little bit about some of the data that we've generated through our clinic in screening for and characterizing children and young adults with behavioral and neuropsychiatric conditions. I think this question about is there such a thing as typical Down syndrome is an interesting one. Because there is a notion, maybe a stereotyped notion of what it means to have Down syndrome. And I think it's important, if you're going to talk about this, to think about it in terms of age or life stage. And I like to think of ages 5 to 6 as kind of a time when you can do that, you can ask that question in a meaningful way, simply because many of the children have received their early intervention and their early preschool. They're ready to transition into the public school system. Brain development occurs very rapidly in the first 3 to 5 years of life. And so while the child is still a product of its environment and its biology, there's a lot that you can say at age 5 or 6 that you can't say at age 2 or 3. So I think if you look at children by the age of 5, I would say that about 75% of the kids seem to fall into this notion of typical. And the way it's defined here as motor, cognitive, linguistic, behavioral, and social attributes, this is how we look at neurobehavioral phenotypes. So most children have mild to moderately decreased tone by this age. The vast majority are walking and running, but some of them have more in coordination than others, and some of them still have noticeably low tone, but the majority have more mild to moderate. Cognitively, it seems like many of the children function in the mild to moderate range of intellectual disability, which is broadly defined as an IQ between 40 and 60. And we know that visual memory and visual processing are much better in most cases than auditory and language-based processing and memory. Speech is usually present in the majority of kids. There may be disfluency or disarticulation. We know that understanding may be better than expression. Behaviorally, many of the children, I'm told, are somewhat stubborn and strong-willed, but the vast majority are also affectionate and very able to cooperate. And many of them are developing good social adaptive skills in terms of dressing, undressing, feeding, toileting, etc. So I think that I would propose that this is the notion of what it means to have Down syndrome in a typical sense. But I would also propose that Down syndrome can result in more than a single neurobehavioral outcome. And that seems to be the case maybe in 25% of cases. So about 5% of cases are actually functioning at a higher level than what I just described, where they have really quite impressive memory and language skills. And if we could find out what's responsible for that particular type of outcome, that would be great. And I would propose that these outcomes are a direct consequence of brain development and the integrity and function of neuronal systems in the brain. No doubt early learning and early environmental opportunities are important, and they play a role in that whole process, especially in the first 5 years. Qualitatively and quantitatively, I think these phenotypes are probably distinguishable from one another. And as I said, they're recognizable, I think, by 4 to 5, 6 years of age with a higher degree of certainty than in younger children. And I think there probably are certain risk factors that contribute to kids expressing one or more of these phenotypes. Now, if you're looking for what are the criteria for establishing a neurobehavioral phenotype, I think you always have to ask the question, compared to what? I mean, we know that these children are going to differ from typically developing kids without learning disability. So the question, I think, is how do they differ from other kids with Down syndrome, this 75% of kids who don't have these neurobehavioral concerns. So I think you need to do a case control design where you're recruiting kids all with Down syndrome who either have or do not have this phenotype or behavioral characteristics of interest. Of course, you need to account for confounding variables such as IQ, age, gender. What are their early perinatal and prenatal histories like? You know, was there something in the NICU or in the early years medically or extreme social deprivation, perhaps, that contributes to their outcome? I think you need to take account of all these factors, as well as the role of intensive early intervention, the frequency, the type, the methods. Obviously, you want to ascertain your children in the same way. You want to use reliable methods for measurement, and you want to have sufficiently powered studies so that you avoid these type 2 errors of assuming no difference when in fact a difference may exist, but you just don't have enough observations to say so with statistical certainty. And I would propose that one approach to looking at these kids in the full sense of what it means to have one of these behavioral phenotypes is to look beyond just behavior. I mean, behavior, particularly disruptive behavior, calls a lot of attention to itself, whether it takes place at home or whether it takes place in the classroom. People are quick to point out when the child is being stubborn or negativistic or aggressive. And what I've found is that more often there's other things that are lurking below the surface than just the behavior. So I think particularly when behaviors become severe or are quite impairing functionally, we need to be looking for signs of atypical cognitive development, the presence of physiologic symptoms, as well as symptoms of emotional dysregulation, if you will. And it's estimated that the incidence of these kinds of symptoms or syndromes may occur in 15 to 20% of children with Down syndrome under 21. I don't think anyone really has a good number for this. So what are some of the specific things that I look for? Well, in terms of behavior, I look for kids with high intensity and behavior that may be harm to themselves or others. Behavior that occurs across environments, particularly if it occurs in home, school, and community. You're more likely to be dealing with a true neurobehavioral syndrome or psychiatric diagnosis than you are just bad behavior in response to some caretaker's request. And like I said, if the behavior is severe enough to interfere with family, peer, and academic functions, that's also a sign that it's quite serious. But some of the physiologic symptoms I look for include disturbance in sleep, appetite, activity level, levels of anxiety or mood fluctuation can be important clues. Neurocognitive changes such as poor regulation of attention or atypical attention, inability to organize their play or their activity in a purposeful way, problems with motivation and planning, problems with social interaction, and of course, developmental regression would be a big red flag. Likewise, if there's a family history of a major psychiatric disorder, such as bipolar, OCD, autism, these may provide clues that are of interest. Now, if we look at kids with disruptive behavior disorders, if you look at the literature on this, and of course there's not a lot, estimates range between 12 and 20% in children with Down syndrome under 21. This seems to be increased compared to the general population, perhaps similar to other groups with cognitive impairment. And the way we define this spectrum of impairments operationally is that you see increasing, what appear to me to be increasing degree of impulse discontrol, hyperactivity, and aggression or destructive behavior. And so if you're a child who's hyperactive and impulsive, but you're not really causing much in the way of disruption or aggression, you may have a diagnosis of ADHD. But if you're throwing furniture or items around the room, and if you're shoving people, pulling their hair, kicking, you're gonna buy a diagnosis of disruptive behavior disorder. And in our clinic, since 1991, we've probably evaluated 80 to 90 such children, which makes up about 9% of the children under 21 that we've seen. I don't think there's a particular outbreak of this in the States or in the Baltimore area. I think this probably represents a referral bias to our clinic more than anything else. Some of the considerations that you need to take into account when evaluating these children is, are they experiencing some occult source of pain or discomfort, which may cause them to be disruptive in response to that? So GI pain due to reflux, menstrual pain in postpubertal females, dental pain, sinus pain, middle ear pain. A variety of things needs to be considered. I've already mentioned the role of ADHD and impulsivity. The vast majority of these kids have some ADHD type symptoms. Some of them are looking a bit autistic-like, but I think we've gotten good at culling those children out of the group, that we don't often mistake disruptive behavior with autism. But much more likely, you may be dealing with an undiagnosed anxiety disorder or cyclic mood disorder. And so that needs to be considered, certainly in children with ADHD and disruption, particularly if they don't respond or they get worse on stimulant medications. And I think many of them do. At least that's been my experience. We also need to consider the role of poor sleep and sleep disturbance. Kids who are not having restful sleep because of micro arousals throughout the night due to sleep apnea, or just a primary sleep disturbance related to their underlying behavioral disorder. Poor sleep can exacerbate these problems and make them worse. Kids with poor expressive skills may experience more behavioral problems like this. We also need to look at what kinds of expectations are being placed on these kids at home and at school. Are they realistic given their functional level? And in addition, parenting style and management style in general. How are kids transitioned from one task to another? Are they prepared? How are requests made? How are limits set? All of these issues having to do with parental or discipline style probably play a role in this as well. Nonetheless, despite all these complicating factors of what contributes to behavior, which is a very complex thing, we have made an effort to try and characterize it using some standardized behavioral tools, which will give us numbers that we could use, I think, across clinics and to measure treatment outcomes and to perhaps better group cohorts for future research. So we looked at 57 kids who are on this disruptive spectrum, compared them to 43 kids with Down syndrome who are more typical. You could see that there's a male preponderance of those with disruptive behaviors, about 3/4 of the kids. Interestingly, I thought cognitive levels were about the same as the typically developing group, which tells me that this is a group that's well aware of its environment and surroundings and is often quite skilled at manipulating caretakers. Children were approximately the same ages, mean ages of about 8 or 9, as were the parents, about the same ages. And using a behavioral tool that is completed by parents, it's a 58-item questionnaire called the Aberrant Behavior Checklist, and it has 5 subscales, 4 of which are useful for this purpose. One of the subscales is referred to as irritability, and that refers to disruptive behavior, aggressive behavior, and some of the moodiness. And you can see that kids who are typical have pretty low levels on all of these subscales, except perhaps being a little bit on the hyper side, as rated by their parents. And kids with disruptive behavior disorder had very high levels of irritability, very high levels of hyperactivity. The scales that were much lower included something called lethargy, which refers to social withdrawal and apathy, and an item called stereotypy, which refers to repetitive movements, such as rocking, waving, shaking. So unlike kids with autism, this group has very low levels of lethargy and repetitive behavior, and very high levels of hyperactivity, inattention, and irritability. And you can see that they do sort themselves out in this very characteristic profile, and the kids who are the most severe are quite easy to pick out using this item. When we looked more closely at the irritability subscale and looked at the 4, I think there's probably 4 or 5 questions that reflect mood and moodiness, we found that there was this linear relationship between, again, this is the typical kids with Down syndrome, and these are the most disruptive kids. They're referred to as group 4. These would be the kids with ADHD. These would be the kids with oppositional defiant disorder. And you can see a linear relationship in kind of this moodiness that exists. And you would actually see the same thing for hyperactivity, disruptiveness, and inattention. It follows this relationship. And in part, that's how we define these groups to begin with. Remember, I told you that we were defining them based on some degree on hyperactivity, disruptiveness, and aggressiveness. So it was no surprise when those things showed this linear relationship, but it was in fact interesting to find that moodiness followed the same trend. Now, we also have an interest in kids on the autistic spectrum, estimated to be 5 to 7% of kids with Down syndrome. This is markedly increased compared to kids in the general population, where the incidence is about maybe 0.5%. And probably this number is decreased compared to kids with intellectual disability in general, although we don't know that for sure. In the last 14 years, we've evaluated almost as many kids with autism as kids on the disruptive spectrum. So that's about 9% of children under 21 that we've seen. And of course, having a child on the autistic spectrum is a particularly large burden and places an inordinate amount of demands on the family and caretakers. By definition, these children have problems with reciprocal social and language activities. They have very restricted, repetitive types of interests, ritualistic behaviors, and very little imaginative or symbolic play. It clearly interferes with relationships and learning. And the kids that we define as being on the autistic spectrum are kids who have autism, kids who have something a little less than autism, pervasive developmental disorder, NOS. And in the general population, Asperger's syndrome is on the autistic spectrum. But we typically don't see kids with Asperger's syndrome who have Down syndrome. Asperger's is considered kind of a high-functioning type of autism. What we do see quite a bit of is this late-onset autism, so kids who manifest symptoms after the age of 3. So we include them in our spectrum. And just to remind folks that sensory dysfunction and peculiar ways of sensory responding, although it's extremely common in kids on the autistic spectrum, and may be common still in kids with Down syndrome, it's not one of the criteria for making the diagnosis. There are some conditions that masquerade as autism that we see quite frequently. So kids with stereotypic movements, particularly the kids who have inattention and sensory dysfunction, can look very much like autism, except that they use language, they understand, and they can reciprocate in a social way, and they can initiate conversation or requests. And so those kids, although they may have many of the same concerns as kids with autism, typically do not get a diagnosis of autism, at least in our clinic. Also, children and adolescents who have obsessive-compulsive traits or disorder, particularly if they have a lot of anxiety and a lot of perseveration, those kids can look quite autistic. But again, because they often have preserved social skills and some ability to initiate communication, usually do not qualify for this diagnosis of autism. We've looked at a large cohort of kids on the spectrum, 61. We've compared them to kids who have stereotypic movement disorders and kids who are more typically developing with Down syndrome. Again, you'll notice a strong male preponderance, including the stereotypic disorders, which I don't think had been well known or well recognized. The vast majority of these kids are trisomy. The remainder are translocation. They're not mosaic or anything more exotic than that. And most of the children, again, were at this age between 8 and 9, which make them a good comparison to our disruptive behavior group. Using an instrument called the Autism Behavior Checklist, which is, it's not really a diagnostic instrument, it's more of a screening instrument, but we also use DSM criteria to make our diagnosis. So using DSM criteria to categorize kids as being on the autistic spectrum or not, when we look at this Autism Behavior Checklist, we find clear differences in sensory dysfunction, social relating, body and object use, which is the same as the stereotypic behaviors, and differences in language function, as well as social adaptive skills. But these three scales really tell the story, and these are all statistically meaningful differences between typical stereotypic behavior and autistic spectrum. When we look on this aberrant behavior checklist, which I just showed you on the disruptive kids, we again see a very clean and clear separation on the irritability scale, this lethargy scale, which looks at social withdrawal and apathy, and stereotypic behaviors, as well as hyperactivity. The speech subscale on this behavior checklist is not of much use, we've found. So interestingly, we are able to distinguish, I think, with pretty good certainty when we get a phone call that a child's having behavior problems. If we can get the parents to fill out this questionnaire and return it to us ahead of time, we will have a pretty good idea of whether this child is on the disruptive behavior spectrum or on the autistic behavior spectrum. And it's really the degree of social withdrawal and stereotypic behaviors that distinguish these groups, not the degree of hyperactivity or irritability / moodiness, disruptiveness, because there you may see significant overlap. So I think this is a useful tool, and like I say, we've started to use it as a way of pre-screening subjects before they even come into clinic. We've also used this aberrant behavior checklist as an outcome measure of medication treatment. I mean, one of the things that we'll do is use medications because the parents tell us that they just are having so much trouble with the child. He or she is not sleeping at night, they're not able to focus. All they do is perseverate or engage in repetitive types of activities. And risperidone is one of the atypical neuroleptics that's known to have a pretty potent effect on these types of behaviors. It's not without its side effects, and it's not without long-term concerns. But in the short term, we were able to document that over a 90-day period, there was a statistically significant improvement. This is based on, I believe, 21 children that we studied who are on the autistic spectrum. We have, about 5 or 6 years ago, we got serious about looking at, what's going on in these kids post-puberty who are going through lots of social transitions in their life and seeming to develop a high incidence of mood disorders, and some of a psychotic type of disorganized quality to it, which may or may not be within the setting of a major mood disorder. And in still other cases, it may be just a lot of apathy and loss of motivation, and major mood disorder or depression, and those who have more of a dysthymia or minor mood disorder. And first of all, we were somewhat taken aback to find out that about half of our subjects were under the age of 21. I mean, I fully expected when we started doing this that this was going to be a problem of adults, as classically defined over 21. So I was somewhat shocked to find that so many young people were developing these problems, and that the mean age that we were seeing these problems was in the early 20s. I mean, we've seen kids as young as 13 and 14 developing these kinds of problems. So here we have a cohort of 41 with mood disorders compared to 17 who are relatively mentally healthy Down syndrome controls. And using an instrument called the Reese scales, which again is a parent answered questionnaire, has 10 different subscales. The highest score you can receive on any subscale is 10. And we found significant differences between the three groups on the inattention subscale and the conduct disorders subscale. There were some subscales that differentiated major mood disorder from minor mood disorder, such as the degree of anger. We found subscales that would distinguish major mood disorder from controls, such as the anger subscale or the anxiety subscales. But these were two that distinguished all three from each other. And just to show you the other 5 subscales, the depression subscale also distinguished all three, as did the social withdrawal subscale. So, we're on our way to being able to characterize these neurobehavioral phenotypes with a little more precision so that we can cohort children and adults to do a more focused kind of research into etiology and response to treatment. And our future direction is to look at more of these complex comorbid conditions, to characterize them using neuropsychological parameters, not just behavior questionnaires, to try and understand if there are specific medical and genetic risk factors or other biological markers, not to mention psychosocial stressors, which are well known to be precipitants of mood disorders. And hopefully we can develop screening guidelines that can be used more broadly beyond just our clinic, but can be used generally for the Down syndrome community and provide better information for families and for physicians. So because of the time, I'm going to just stop right there. Thanks for your attention.